Today we discussed one of the most important subjects in GIT. It's an upper GI bleeding. Upper GI bleeding will present most common cause of emergency in medicine. Most cases with coming in ER or in emergency coming with upper GI bleeding. The upper GI bleeding, for definition, we can classify the upper GI bleeding in gastrointestinal tract in upper GI bleeding and in lower GI bleeding and bleeding rectal. For simplicity, so we get here upper GI can be defined as a bleeding that occurs in the digestive tract proximal to the ligamentum of Treitz. Ligamentum of Treitz occurs as the second part of the duodenum. So it's linked here to the second part of the duodenum. So all parts in the upper GI could be presented by bleeding. Could be a causes from the esophagus, could be the causes from the stomach, could be from the upper part of the duodenum. So all these areas coming with a bleeding, upper GI bleeding. For simplicity, we can classify esophageal causes here and gastric causes, duodenal causes, causes from the neighboring structure nearby the gut, stomach and the alimentary tract, and sometimes we get a systemic illness could be presented by bleeding, and special forms of vascular disorders and hematological disease can come with increased bleeding tendency and upper GI bleeding. So, what is the etiology of upper GI bleeding? First, as we said, from the esophageal cause. So, esophagus could be presented by, first of all, esophageal varices. What is esophageal varices? Esophageal varices is a systemic shunt from the portal to the systemic circulation. This dilated channel or vessels come with portal hypertension and with liver cirrhosis and portal hypertension. These channels become ruptured with undertension. So, esophageal varices present dilated portal systemic shunt. These shunt communicate between portal system presented by esophageal branch of the gastric and short gastric. Here is the gastric and short gastric vessels, which is a portal tract, and at the same time systemic vessels presented by thoracic esophageal branch of the esophagus. So this area in the lower end of the esophagus present a communication. This is all the portosystemic shunt occurs in the abdomen. So the most important area is here in the lower end of the esophagus, as presented by esophageal varices. Here this is the cartoon presented by the diagram of these vessels at the lower end of the esophagus, with communicating the junction between the stomach and the esophagus. Here is the endoscopic picture of the varices. We come with the endoscopy and come with a video endoscopy to view this dilated tortuous vein inside the lumen of the esophagus. When it ruptures, he comes with this picture, with a massive, horrible bleeding like tabbing. So excess bleeding comes within a few minutes. The patient will lose a lot of blood within a few minutes. Another picture with four esophageal varices, and one varix was beaded, dilated, and tortuous. And here the site of bleeding, and the area will be so red from the acute bleeding. The second most common cause of upper GI bleeding from the esophageal cause is esophagitis, simple esophagitis, or gastroesophageal reflux disease. GERD, what's called GERD, gastroesophageal reflux disease. It could be a linear ulceration in the esophagus, what's called esophageal ulcer. So, at the lower end of the esophagus, normally, the esophageal lining epithelium of the esophagus is stratified squamous epithelium. But the lining epithelium of the stomach is simple columnar with goblet cell, which accommodate to secrete HCl and coact with this high pH. Okay. So this pH will come in contact with the squamous cell. It will come with irritation. It's a chemical irritant, making inflammation and gastroesophageal reflux disease. So this is the lower end of the esophagus and the junction between the gastric mucosa and the esophageal mucosa, and this reflux makes sometimes with repeated reflux make an irritation and esophagitis with upper GI bleeding. This is the picture with reflux, the linear ulceration with necrotic base and grade 4 reflux, and this grade 4 reflux coming with acute upper GI bleeding. This is the whole picture of one patient coming with an esophageal reflux with a peptic ulcer disease and multiple small erosions in the stomach, and at the same time he has a small ulcer in the duodenum. So he has multiple lesions in one patient with severe reflux in the esophagus, and antral ulceration and small erosions, and duodenal ulceration. As regards the reflux esophagitis, one of the most common complications of reflux, repeated irritation of the lower end of the esophagus. So it may make something which is precancerous condition, what's called a Barrett esophagus. A Barrett esophagus is a documented lesion which is a precancerous condition. Why it's a precancerous condition? Because the normal stratified squamous epithelium inside the lower end of the esophagus will make a dysplasia, will be changed into intestinal mucosa or a gastric mucosa. So a change of the stratified squamous epithelium in the lower end of the esophagus and replacement with dysplasia, replacement by a gastric or intestinal mucosa will cause a Barrett type of esophagus, which is a precancerous condition. So I can see it by my naked eye, and the mucosal pattern of the esophagus lower end with its brightness changed. As they take a biopsy, and with this biopsy, with microscopic picture, will give the picture of dysplasia. So dysplasia of the lower end is a Barrett esophagus, which is a precancerous. Here is the Barrett, so we can make a special stain for the lower end to make the cells more prominent and make it obviously seen by naked eye, so we can see it, the linear epithelium here with metaplasia in the each. Sometimes very simple infection. It could be an infection. The most common type of serious infection coming with bleeding is candidiasis. Candida of the lower end of esophagus. This is a batch of candidiasis. This is special interested cases, a patient with varices and on top a candidiasis. So he has a portal hypertension, and as he is a liver failure and immune compromised patient, so he comes with infection with candida. So candida batches come on top of esophageal varices. So he has two causes for upper GI bleeding. The third cause of bleeding is hiatus hernia, diverticular disease in the esophagus, foreign body in the esophagus, mallory staph. Each lesion of these different causes will make bleeding. What is hiatus hernia? Hiatus hernia is the displacement of the junction between the esophageal and gastric junction above the sphincter. So we can, most commonly, the sphincter must be here. So sliding of the sphincter to this area in the chest, making what's called sliding hiatus hernia. Sliding hiatus hernia. So irritation of this lower end make it irritation and esophagitis and bleeding. On the other hand, it may be another type of hiatus hernia, what's called a paraesophageal hernia. In surgery, we'll take it in details. So a paraesophageal hernia will come. The sphincter is at the same position, but a small portion of the fundus of the stomach will bulge beside the stomach in the thorax. So it comes with paraesophageal hernia. So both of the two types of hiatus hernia will be come with hematemesis. The verticular disease is one of the bulge of the mucosa of the intestine, as the intestinal, most commonly intestinal disease, but it can be affect any part of the alimentary tract. It could be presented in the esophagus also, in the stomach, in the duodenum. Any diverticular disease, once it causes a diverticulitis, it causes a horrible bleeding, and severe bleeding will be okay. A Mallory virus tear. What is a Mallory virus? Mallory virus tear is a tear inside the mucosa, like a linear ulceration, after repeated attack of vomiting, and especially with strain of vomiting. The patient was vomiting repeatedly, so this serious and forced vomiting will make a break inside the mucosa of the esophagus. This break or scratch-like picture make a bleeding inside. And this picture, most probably the blood will be bright and mostly with arterial pattern. It's not a venous blood, it's an arterial blood. A foreign body picture, we can see patients coming with different foreign bodies can be swallowed, especially in children or old age, our psychosomatic disorders. So patient may come with sharp object or nails or something like that, which injury inside the alimentary tract, so come with bleeding. Achalasia of the esophagus with aganglionic segment in the lower end of the esophagus, also presented by hematemesis, and lower end cancer of the esophagus also will be presented. This is the cancer area of the esophagus. This area will be highly malignant, and the mucosa of the malignant tissue will be necrotic, and because it takes a lot of blood supply, and with necrosis it comes with a bleeding ulcer from the top of the cancer. So cancer of the lower end of the esophagus or esophageal cancer can be presented by a bleeding. And one of the most serious cancer and with very bad prognosis, cancer esophagus. Other causes of gastric and duodenal causes. Number 2. First, for simplicity, it is a gastric ulcer and duodenal ulcer. 1/3 of the patient coming with ulceration or causes of the gastric and duodenal causes come due to gastric ulcer and duodenal ulcer. Sometimes the ulcer is not so big. Sometimes we find a very small ulcer, as we will see, maybe a half centimeter, coming with a severe horrible bleeding because it comes overlying the vessel. If the ulcer coming over the vessel, it comes with horrible bleeding. Sometimes the ulcer is very big and coming without bleeding at all. So the size of the ulcer is not corresponding with the bleeding, but the site of the ulcer overlying a small vessel is correlated with the bleeding. As we see in esophageal varices, also the portal hypertension will be presented by a fundic or gastric varices. One of the complications of portal hypertension is present of these varices. Also can be presented what's called portal hypertensive gastropathy, a PHG. Portal hypertensive gastropathy, we will see that this picture. The mucosa, all the mucosa of the stomach, especially in the body and the fungus, will be presented by mosaic pattern of congested edematous mucosa, and all sides of the mucosa will be bleed. There is no special site or distinct point of bleeding. All the mucosa inside the stomach, all over, come with bleeding, with severe congestion. And also what is called GAVE, it's gastric antral vascular ectasia. What is gastric? Gastric is the stomach. Antral, it is the site in antrum of the stomach. Vascular, it is a blood vessel. Ectasia, it is a dilated ectatic vessel. So, with a portal hypertension, 3 lesions most probably, either a fundic or a gastric varices, number 1, portal hypertensive gastropathy, number 2, and the gastric antral vascular ectasia, number 3. So three main causes of portal hypertension can be present. The ulcer cannot be large as we said, but it could be presented by erosions. What is different between erosions and the ulcers? The ulcer is the discontinuation of the mucosa and the submucosa. But in erosions, just erosion, like abscess ulcer you can see here in the mouth, in children, most common, it is an erosion, small erosions. The discontinuation of just mucosa of the stomach and duodenum. So it comes with a very, very minute lesion could be presented by hematemesis. Gastric cancer. Gastric cancer will be a large cancer that when detected, because the stomach is capacious organ. So when the lesion grows inside the stomach, it cannot be detected early. The patient comes maybe with some dyspepsia, upset, which comes as a dyspepsia. But when it becomes a very huge, it will become with metastasis and with complication and with liver metastasis most commonly and with very, very bad prognosis. Sometimes we get the patient comes with, especially nowadays, the abuse of drugs with intake of non-steroidal, intake of some hallucinogenic drug. So the patient with iatrogenic or he take medications that come with ulcerations. So it comes with iatrogenic ulcer by drug or acute stress ulcer. Acute stress ulcer, especially in case of accident, in case of burn, in case of myocardial infarction, severe stressful condition may come with ulceration. So the patient will come with ulcer. Also diverticularly of the stomach and the duodenum, one of the general diverticular disease of the alimentary tract. Now this is the ulcer. This is a small ulcer. This is the mucosa inside with rouget inside the stomach. And we get a small ulcer inside here. So it could be not due to non-steroidal, or it could be due to a Helicobacter pylori or infection by this organism. So we must treat the etiology of the ulcer. So we can manage the patient with peptic ulcer if it is drug induced, stop the drug. If it due to Helicobacter pylori, we treat it as we will see. Here is the site of the ulcer. Here is a small oval. The ulcer here overlying is the pyloric ring. It comes over this is the pyloric ring. So it is make a deformity of the pyloric ring and it comes here overlying. It comes sometimes in the fundus. Here is the fundus of the stomach, and this is small ulcer inside, and with black ulcer base denoting recent bleeding. So the blood clots overlying the ulcer denoting acute bleeding. Here is a small ulcer here with a black base also. This is a gastrojejunostomy with also with ulceration, patient with operation surgery before. These two cases in the duodenal cap. So this is the duodenum, and like the endoscope coming from the duodenal bulb to the second part of the duodenum. So we get an ulcer in the one limb and the ulcer in the opposite limb. So this is what's called the kissing ulcer. Kissing in the opposite limb, in anterosuperior aspect and postero-inferior aspect of the duodenal bulb. Here is the same sign, and this is the one ulcer, and this is the one ulcer. So ulcer opposing each other. This is from the duodenal ulcer. Another small but penetrating deep ulcer here in the stomach also. And this is with acute bleeding here, and spot and a small artery. It's a small ulcer but with excessive bleeding due to overlying air vessel. We have stigmata of recent bleeding. So if the patient comes with a clean base, or it comes with an active bleeding or adherent clot that we can see, so we detect that the patient, this is the source of bleeding if he has an adherent clot overnight. this is the picture of fundus and gastric varices. This is the fundus. It is the dome of the stomach upside, and we come with the endoscope from the esophagus and coming down and making a U-turn and coming up to see the fundus of the stomach. So we can see ourselves here. Part of the endoscope coming from the esophagus will be seen, and the other side coming to see the fundus. Here is like a cauliflower mass. This cauliflower mass is the left gastric branch of the branch of the left gastric, which is dilated and tortuous and making this picture. And this is the site of bleeding here, and this is the linear ulceration here that will come with bleeding. This bleeding from the fundic varices characteristic is a horrible bleeding because it comes directly from the left gastric and short gastric veins, and the patient will lose a lot of blood within a few hours. Coming to the portal hypertensive gastropathy and gastric antral vascular ectasia, this is the picture of the gastric antral vascular ectasia. This is the antrum, and we found this severe congested mucosa here, the mucosa like skin of the measles. So this is minute from the dilated visible capillaries underlying the mucosa of the stomach, giving this picture. And this is ectasia. This is this ectatic visits in the antrum, and this is the pyloric ring. And also about the congested mucosa. This is the mosaic pattern. If we clean the stomach underlying and saw the picture of the mucosa underlying, this picture is the mosaic pattern of gastric mucosa, and this is the congested hypertensive gastropathy in the fundic mucosa. The gastric cancer, as we said, the gastric cancer will be almost, we found it a huge size before it can be symptomatized. So this huge size can be in the body, in the antral or the fundus. So it will be large like this, and with excess necrosis overlying and the site of bleeding here. So excess necrosis of the whole mass coming with a bleeding. Here is the site of necrosis, and this is bleeding. Number 3, coming first with the esophageal causes, second with the gastric and duodenal causes, third is the disease of the neighboring structure beside the alimentary tract. Which is important is hemophilia. Hemophilia is the bleeding inside the biliary tree. The bleeding most probably coming post-traumatic, maybe external trauma or accident or something like that, or mostly with surgery, post-surgery, with laparoscopic cholecystectomy. During the laparoscopic cholecystectomy, one of the clefts may be dislodged, and the patient will bleed inside the biliary tree and coming with hematemesis due to hemophilia. Hemo, blood or bleeding, biliary tract. So bleeding inside the biliary tract after surgery or laparoscopic cholecystectomy. One of the causes, it can be recorded, but we cannot see the patient. The patient will die before we see the patient. Is the aortic rupture inside the esophagus, maybe due to aortic aneurysm or something like that. So will be compressed the esophagus and make a necrosis and the rupture inside the esophagus. So the patient will die in peace. Systemic disease. The patient comes with no local lesion. We cannot detect a local lesion inside the alimentary tract, but he can be presented by a systemic illness which presented by upper GI bleeding. So what is this presented disease? It could be due to hypertension. Hypertension alone may cause a bleeding at any part of the body. Maybe hematemesis, maybe hemoptysis, maybe melena, maybe bleeding per rectum, maybe epistaxis, whatsoever. Any site can be presented by bleeding due to increased blood pressure alone. So systemic illness with hypertension can be presented by. Patient with a chronic renal failure, can be presented patient with abnormal uremia and with high creatinine and this defect in the coagulopathy and defect in the bone marrow with platelet defect, so making all these criteria making the patient liable for bleeding. And many times we first have the patient with presented for chronic renal failure presented by melena or hypertension. Okay.
Level of hypertension, which
level is high. It's not hypertension. It's high, above 200. It's an extremely high level of hypertension, which could be presented by. It's not an hypertension, mild or moderate. It must be a severe, acute rise in the blood pressure. It's acute. So the small vessels will be ruptured under this pressure, and the tension of the hypertension make it bleed. Okay. So the second is chronic renal failure. So one of the main manifestations of the chronic renal failure, the patient can be presented by an attack of hematemesis. Systemic infection. It could be any type of infection. We can the patient presented by red rectal infection, maybe presented by pneumonia, chest infection, bronchitis. Any source of infection can be. It's a systemic illness, so it can be coming with fever, bleeding, whatsoever. All these coming with bleeding. Connective tissue disease, we will discuss it later on. It could be a vascular or connective tissue disease affecting the connective tissue of the blood vessel itself. So blood vessel, the wall of the blood vessel is formed of connective tissue. So if defected in the wall of the blood vessel, so under any condition, sometimes it comes with bleeding, the defect will be ruptured. So we will see it later. And some diseases like amyloidosis, sarcoidosis on the wall of the vessel also coming with it. Coming to the last vascular and hematological disorders, one of them is the purpura. Purpura with a bleeding defect in the platelet, and thrombocytopenic count of the platelet is defect. It could be a defect in thrombocytopenic count of the platelet or thromboasthenia. Thromboasthenia, it means defect normal count but defect function of the platelet. So maybe a count is low or the function is defect. So all the defect on the platelet will come with a bleeding tendency. Henderson-Lyon purpura, maybe in children also. Also, we come with the clotting cascade, with an external cascade or internal cascade. If the clotting factor in this cascade, there is a defect in any factor of the clotting factor, it will come with a hematological abnormality with a bleeding. So the defect in the clotting factor is one important, because the only treatment of this patient is replacement. We replace the clotting factor. So we must diagnose which factor must be defect and replace this clotting factor, and the patient will cure. Polycythemia vera with increase the level of the RBCs will come with increase also the liability of bleeding inside the vessel with rupture of the blood vessel. One of the most problematic disease we sometimes face in the ICU or the emergency is what's called disseminated intravascular coagulation, in which the patient has two opposite disease at the same time. He will bleed from different orifices, and he has at the same time multiple thrombosis inside the body. So he gets two opposite disease at the same time, the disseminated intravascular coagulation with excess bleeding from many orifices and multiple thrombosis inside the vessel. Hereditary hemorrhagic telangiectasia. From its hereditary, it is a familial or hereditary hemorrhagic with tendency of bleeding, and telangiectasia with ectatic of the blood vessel. This telangiectasia can be presented in the skin as well as the mucous membrane. So any telangiectatic area can be ruptured at any time without any precipitating factor under certain condition. So it comes with what's called obscure GI bleeding, which is very difficult to be diagnosed because after rupture of this vessel, everything is normal. We come with endoscopy, with barium, with CT, everything is normal. But there is only rupture of the blood vessel through telangiectatic area. This is two cases with two causes of vascular connective tissue disease, what's called pseudoxanthoma elasticum. The elastic tissue of the vessel of the wall will be defect, so we can bleeding rupture this vessel easy, or what's called Ehlers-Danlos syndrome. So two connective tissue disease coming with hematemesis is pseudoxanthoma elasticum and Ehlers-Danlos syndrome. So we finish the etiology of the upper GI bleeding. Coming with what is the clinical presentation? The patient come to ER or emergency, or the patient come with what kind of symptoms? First, the patient come with a hematemesis. What is the definition of hematemesis? Our GI bleeding come with hematemesis is a bloody vomitus. So it must be a vomitus, not a coughing of blood, to be differentiated from the hemoptysis. So hematemesis is a vomiting blood. It must be fresh. It could be fresh. It could be. But most commonly, it is a dark or altered blood which gave the character of cafe ground, like cafe. Like this cafe ground due to altered blood by HCl. So HCl inside the stomach will change the color of the brightness of the blood into cafe ground appearance. All cases of hematemesis must, I say must, underline a red color, be followed by melena. There is no hematemesis without melena. But sometimes the patient can be presented by melena without hematemesis. Maybe the lesion will be lower down in the duodenum, so it comes without backwash, or there is no duodeноgastric reflux of blood to come with vomiting. So the blood coming with melena, but it is an upper GI. But the patient, there is no hematemesis without melena. Once the patient bleeding from the upper GI side, he must be. So this is one key to differential diagnosis between one patient who is coming with malingering, asking for vacation, or asking for report to have that he has a hematemesis, and when we ask about what is the color of his stool, he has a stool normal. So he is not hematemesis at all. There is no hematemesis without melena. So you must differentiate it definitely. What is melena? What is melena? Melena, it is a black. It must be a black. Definitely black. It's not a dark. It's a black. Tarry. It's not a solid. It is a tarry. Offensive, very offensive. Once you smell it, you will know it very much. It's very offensive. It's very sticky to the ground. Very sticky. And very shiny. Bright. Stool due to bleeding above the ileocecal bag. So this character is melena. Otherwise, it's a dark stool. If the patient coming with it, it is like a tar, which we use it in يسموه بلاك اللي بنرسم بيه الشوارع. This is like black. So melena, it's a black, tarry, offensive, sticky, shiny stool. This must be 5 characters before we can define melena. Okay. What's the question?
We said that hematemesis blood must be fresh. Is this
no, it's not must. Sometimes, I said sometimes. definitely. It is sometimes fresh. Why sometimes fresh? Because if it comes thrown out the blood, if there is streak inside the esophagus and the patient will spit it out or vomiting the blood coming from the esophagus before it is changed in the stomach, so it's coming with the blood. Or if there is a huge amount of blood, is a horrible amount in a very small time and he vomiting it rapidly, so there is no time to be changed to acid hematine. So acid hematine, it is a dark coffee ground. So if it not changed, so it will be bright. But if the patient has a vomiting from the esophageal cause, a gastric cause whatsoever, and the blood is still inside the stomach for a while, it will be definitely changed. Okay? Okay?
Okay.
Maybe, as we said, the patient comes with a horrible blood in the GI, so the amount of bleeding comes very rapidly along the alimentary tract. It comes from what's called the hematochezia with a bright red, not a melena, what is called a maroon blood. Maroon blood. Maroon blood. If it is, especially if the upper GI more than 1 liter within a short time, and it has a purgative action, so the excess bleeding comes in the GI very rapidly, so it not come with melena, it's coming with a maroon blood with a jelly-like structure. It is a brownish red in color. It's not a melena. So, but must be connected with the amount. If the amount is horrible amount, it is an upper GI bleed. If the amount is small, it is a lower WA, because we have many diseases, especially diverticular disease or diverticulitis, with a maroon blood due to a lower GI bleeding. So it's most commonly with a lower, but only if it's a blood. So don't forget if the blood more than 1 liter, it will come with a maroon blood. Sometimes the patient has a leak inside the lesion. It's not an open lesion like a vessel or something. So it is a small loss of blood, minute loss. So it comes with something which is called occult blood in stool. Occult blood, it is not obvious. I cannot see it by naked eye. It can be diagnosed only by microscope. So we take a stool sample and ask in the lab to make an occult blood in stool. If the occult blood in stool is positive, so this patient will have a loss of blood, but in a minute amount, in a small amount that is not seen by the naked eye and cannot be changed the stool to melena. But it will take a long time, so that the patient comes with a chronic loss of blood, coming with presented by severe anemia, and we cannot, and dizziness and low cardiac output symptoms, and sometimes heart failure from this severe anemia with blood loss due to occult blood in stool for a long time. The patient comes with severe bleeding, but there must be many complications on all sides of the body. What are complications of this bleeding? The patient with a lot of blood in a short period. So the patient will have definitely, the patient come with a cardiovascular symptoms, especially shocked. You're dealing with a bleeding person. Whatever is it, this bleeding coming from the accident, whatever bleeding coming from emergency, what? You are coming from internal hemorrhage due to rupture of esophageal varices and or bleeding ulcer. So first presentation by the bleeding shock, hemorrhagic shock. And disturbance in all biochemical parameter inside the body. So this biochemical complication is, first I'm afraid about the kidney. Kidney is a very big, very important organ for me. Don't forget to assess the kidney all the time in all patients, because kidney, if the patient will be patient with shock, with loss of a lot of amount of blood, with low oxygen tension inside the blood, the oxygen coming to the kidney is very, very low. The amount of blood is very, very low. So coming with the patient with shutdown of the kidney, with the patient with acute necrotizing or with uremia, acute renal failure. So the patient comes with an uremia in a very short time if the patient persistent with bleeding and shock. We come the patient vomiting repeatedly, so he will lose a lot of HCl. So coming the patient with alkalosis and severe dehydration. Don't forget to replace these electrolyte disturbance inside the patient and decrease the glomerular filtration rate, so the urine output of the patient is very low. So when we come to treat the patient, first line of treatment to resuscitate the patient to assess the kidney function. We are afraid about the kidney function and urine output here because urine output will be decreased. So first of all, insertion of the urinary catheter and assess the amount of urine every hour. Don't forget that the blood inside the gut will change, increase the level of the ammonia level, and the patient with chronic liver disease and liver cirrhosis with increasing ammonia level coming with hepatic encephalopathy. So hepatic encephalopathy, one of the most common complications of the patient with upper GI bleeding, and this is one of the emergencies, another emergency, not only for a shock and the bleeding, but the patient comes with hepatic coma. So hepatic coma, another emergency. Patient under stressful conditions, so sometimes the blood sugar will be high. If he is previously diabetic or not diabetic, the blood sugar is high. It's a stressful condition. Sometimes the patient will come in with increased or impaired liver function test. The shock per se will make the patient with restlessness. The patient is irritable, sometimes refusing help, refusing admission to the hospital, refusing IV line, refusing blood transfusion. So this irritability indicating that the patient in shock. The patient will come maybe low cardiac outputs with blindness, severe vasoconstriction of the blood vessel, hepatic coma, cerebral coronary insufficiency. All these complications come with the patient on upper GI bleeding. So what we plan, how to manage this patient with upper GI bleeding. So first of all, you have to plan at the same time, parallel, immediate at the same time. First, you get a patient with a shock and bleeding. So you first resuscitate the patient, whatever the etiology. You manage a patient with shock, so you must resuscitate first. Once the patient coming with resuscitation, starting to identify the etiology, what is the cause of this bleeding, and at the same time to stop by any means this bleeding. So these two parallel roads or the roadmap of treatment of upper GI must be parallel at the same time. We don't start with one or another, but the two arms at the same time. How to resuscitate the patient? For initial assessment of the patient with upper GI bleeding. First of all, we measure the vital signs, the parameter of vital signs, the pulse, blood pressure, pulse, every 20 to 30 minutes in the first emergency, and then every 4 minutes, 4 hours. Because the patient in every stage is still in the active bleeding. So we need a close observation of the patient. We need a rapid decision if the patient comes with rapid pulse, so the patient in acute bleeding, or the patient comes with normal pulse but he comes with hematemesis, so it is an altered blood and the bleeding spontaneously stops. Sometimes the patient spontaneously stops bleeding, so the pulse may be within average normal. We record the urine output. We put immediately a 2 large IV line in both arms because we get a patient with a shock and we get a patient with a bleeding. So we need one line for a blood transfusion or or factor deficiency or plasma or albumin, whatever, and the opposite side for fluid to replacement is this fluid shock. We take a blood sample immediate in ER and make a cross-matching for a type of blood grouping and RH and make a reservation of the blood bank and make a cross-matching with making a complete blood picture, prothrombin time, bleeding time, liver function test, renal function test, and electrolyte disturbance, make it immediate first sample of the blood in ER. We insert a nasogastric tube. We insert the patient with nasogastric tube, one of the emergency, so we can diagnose the amount of bleeding, how amount the patient will bleed, the character of the bleeding, if it's acute or altered blood. We can make a wash with all the gastric mucosa. We can remove the HCl inside. We clean the stomach. Firstly, because we come next with the endoscope inside the stomach, so if he has a lot of bleeding inside the stomach, so we cannot see anything inside. So we must insert NG tube and make a wash with ice saline or anything to suck all the blood inside and remove the gastric mucosa and detect the recurrent bleeding. Okay, so nasogastric tube is very important to assess the amount of and the rate of bleeding, to monitoring the recurrence of bleeding, and to remove the amount of blood, excess amount of blood, to avoid the patient to come with hepatic encephalopathy or hepatic clot. Then after resuscitation must be done in the ICU. Typical in ICU, we give a fluid and the oxygen and monitoring the vital signs and give a blood transfusion, and sometimes we give a whole blood and sometimes we give plasma and sometimes we give a bagged RBCs only to avoid overload on them. Then we come to the two arms at the same time, treatment of the cause and stop the cause. Treatment of the upper GI if the bleeding coming due to rupture of GI vessels. What can we do? First of all, we come with balloon tamponade. What is balloon tamponade? It's a mechanical compression of the vessels. Mechanical compression is a tube with a two lumen, one of the gastric two balloon. First balloon is the fundic balloon or gastric balloon, and the second balloon is the esophageal balloon. And it may be a sanguistatin. This is a sanguistatin Blackmore tube, and there is with 3 lumen, and we get a little necklace tube with 4 lumen. So this is 3 lumen, one of the lumen for this balloon, gastric, and the second for the esophageal, and the third one to wash and clean the gastric content. So this is the third tube. What about the necklace, little necklace tube? The fourth tube coming here is to wash and cleaning the lumen of the esophagus. So we get another 2 balloons, gastric and esophageal, and 1 tube for the gastric wash and 1 tube for esophageal wash or such. It has a hazards and complications, and we can take it in instrument. One of the most important instruments in GI is the sanguistatin. But what the medical treatment, medical therapy can do the patient to stop the bleeding as we can, or to decrease the portal hypertension. This is the target, our target, to decrease the portal hypertension from which the bleeding comes or esophageal varices come. So to decrease the portal hypertension, we can use a simvastatin, which is a longest-acting somatostatin analog, by 100 microgram, giving IV bolus, intravenous, 1 bolus, and then 50 microgram every hour later on, until the bleeding is stopped. So the decompression of the mesenteric vessel and portal hypertension will decrease. This is the one important. This is an old, very old treatment, is a vasopressin unit. A vasopressin has a very vasoconstrictive, very important and make maybe vasoconstriction to the cerebral vessels and maybe coronary vasoconstriction. So it has many hazards to the patient. So it no more use of vasopressin, but it is synthetic derivative of vasopressin, which is terlipressin or glabressin. So nowadays we use sandostatin or glabressin to making a portal decompression of the portal hypertension. How to stop the bleeding? By endoscopic therapy. First of all, it is emergency endoscopic in the first 12 hours after admission, and it must be after resuscitation of the patient. The patient will come with endoscopy. This cartoon showing the picture of the esophagus with the whole this esophageal and coming with the endoscope and the needle inside and inject inside the varix to make by sclerosing material, making a chemical irritation. This is chemical irritation and inflammation end by fibrosis. So fibrosis of the varix will stop the bleeding. But also it has a complication because the patient will get some dysphagia after injection sclerotherapy, sometimes fever, sometimes recurrent bleeding. It could be recorded. Sometimes we get infection, pleural effusion, or even bacteremia. This is a picture of this needle. The needle like a very small instrument coming inside the endoscope from the inner channel in the endoscope itself. After introduction of the endoscope inside the patient, we come to a certain hole inside, coming with a needle. We come this needle inside the patient with coming to the site of bleeding and inject below this to make a stop of bleeding, and this is another injected of the varix. Or making what's called esophageal band ligation. Band ligation is a rubber band. This rubber band will suck the varix and will close around the varix, so the varix will be squeezed and will be necrotic later on, and in this necrosis ended by fibrosis. This instrument will be put overhead on the endoscope, and this tip of the band will be maybe 5, maybe 6, maybe 7 band. This band will be on the top of in the tip of the endoscope. So we come at the head, this head here with the handle, and this band on the tip of the endoscope, and we make firing of the band every time. This, after firing of the band, it will be like this. So this varix will be sucked inside this, and then we'll firing the band and make a closure of around this varix. This is another varix here. This is the cup of the band instrument, and this also here. This is the band, and this is the varix will be sucked and banded. So we make more than one band, and this band coming overlap all the esophagus as the site of the bleed, and this is the site of band. This is the site of bleeding. How it is horrible to have a bleeding. This is the site, small hole in the varix, and this is come with a horrible bleeding like that. So if you didn't stop the bleeding, the patient will lost a lot of blood within a few minutes. We can do an interventional radiology. Interventional radiology have an upper hand here in the treatment of portal hypertension and making a shunt inside the liver. This shunt, what is called transjugular intrahepatic portosystemic shunt. This transjugular intrahepatic portosystemic shunt, this is a small shunt coming can be introduced from the jugular, internal jugular here, and coming to the hepatic vein to the right branch of the portal vein. So from the right branch here to the right branch here, this is a small link, making decompression of the portal hypertension to decrease the esophageal varices or the fundic varices. But also it's very expensive, and it has a complication because the shunt may be thrombosed, or the shunt may be need recurrent repeated shunting later on. If the patient has a gastric varices, so this gastric varices also has in esophageal varices we have a special material for injection, what's called ethanol amine oleate 5%. This material is ethanol amine oleate, is an oily material. But in fundic varices I cannot use ethanol amine anymore. This is a special material which is a glue-like a glue. This glue will stop bleeding as immediate, like we put it a glue on a paper. So this material was called histoacryl glue. Histoacryl, once injected inside the veins, it will be solidified immediate once it is contact with the blood, so it will stop the bleeding at once. So we get here a jet of blood. We come here with, this is the fundus and this is the fundic varice, and we get jet of blood. So the stomach will have a lot of blood inside from a very small hole. So here the fundic varices, and this is the site of bleeding. Here, very interesting, I do it myself. This is the needle, and this is the bleeding, and the blood coming solidified at once, so the drop will stop. Okay? So it's very interesting picture. The bleeding coming is like a jet of blood, and once injected, the bleeding freeze, like a freeze. It stops. Coming to the portal hypertensive gastropathy, this is a picture. You can see all the mucosal wall of the stomach coming with a bleeding. You cannot identify one side which you can dealing with. So the only way to deal with it is a portal decompression by medical or argon laser application to all sides of the portal hypertensive in the stomach. Here is the antral gastropathy. Also, coming to the non-pharyngeal bleeding, which is affecting ulcer disease. How can we deal with this ulcer if it's bleeding or a small minute erosions inside? These all erosions coming with bleeding. So how can you deal with it? Either if we get an ulcer, we can inject this ulcer or around this ulcer by diluted adrenaline, 1 to 10,000 dilution, to making vasoconstriction of the blood vessel underlying, which is the bleeding. Or we can use a hemoclip, which is a surgical clip. We can use it overlying. This is a surgical clip, small, very small, minute clip. We can use it applied on the site of bleeding and applicable here, and making the stop of this bleeding at once. How can we use an obscure upper GI bleeding? What is the obscure upper GI bleeding? Okay, 5 minutes. What is the definition of obscure upper GI bleeding? Obscure upper GI bleeding is an acute or chronic gastrointestinal tract bleeding for which there is no marvelous or visible or can be determined by routine endoscopic evaluation to the patient with a bleeding, and I do all investigation, I cannot detect the site of bleeding at all. So it's an obscure, unknown, very difficult to be diagnosed. Either because the test cannot be performed, or because the result has not been inclusive. I cannot definitely diagnose it. So what are the causes of obscure upper GI bleeding? Which is very difficult for me as a doctor and difficult to manage to the patient, and the bleeding will be excessive. Most of the obscure upper GI bleeding, due to small intestinal cause. Small intestinal causes may be a benign tumor, or lipoma, leiomyoma, or carcinoid tumor, or malignant metastatic lesions in the small intestine could be, or maybe a malignant tumor inside leiomyosarcoma, lymphomas, diverticular disease like a Meckel's diverticulitis, or maybe an ulcer, a idiopathic ulcer, or ischemic colitis in the small intestine. So sometimes vascular causes vascular anomalies like telangiectasia and cannot be detected and can pass without unnoticed, maybe like a redness area or something unnoticed. So we repeated the endoscopy several times to be diagnosed. So vascular anomalies sometimes maybe with skin lesions or sometimes without skin lesions. Vascular anomalies with skin lesions like hereditary hemorrhagic telangiectasia, as we said before, or rhabdo-ocular Weber syndrome, or blue rubber red neighbor syndrome, or crest syndrome. All these coming with a vascular anomaly inside and with skin lesion. But sometimes without skin lesion, like angiodysplasia or vascular atresia or arteriovenous malformation. The Laffoy ulcer, one of the Laffoy ulcers, very difficult ulcer. It is an ulcer. It's not an ulcer. It's an undilated arterial vessel inside the stomach, usually in the fundus, and coming with horrible bleeding. So it's a Laffoy ulcer. I have one patient with a Laffoy. It's a rare disease, but it could be you can facing somebody like that. Bleeding from the biliary and pancreatic also very difficult to be diagnosed. Hemophilia is very difficult. Arterioenteric fistula also could be presented. Vasculitis syndrome or amyloidosis. Elastic tissue or connective tissue disease, one of the etiology of the neck. So it is very difficult to be diagnosed, but nowadays we get a capsule endoscopy. A capsule endoscopy making the patient will be swallowed, special capsule. This capsule will come with the patient and will making a cut inside the intestine, also from the swallowed part until it coming out from the anus. So also it will be cut. This cut will be put on the software of the computer, and you make an analysis to these cuts pictures. These pictures all through the GI tract. A small capsule. I have picture of this capsule. This small capsule, like a capsule, it has a camera and a flash inside. So it make a flash and they take a picture in all cuts, so it can detect any lesion also, especially in sometimes in areas which you cannot be seen, either by our endoscopy or our lower endoscopy, especially in small intestinal lesion, you cannot be reached. So the capsule will be very important for diagnosis. A small bowel X-ray or maybe a bleeding scan or maybe a stomach scan by a technician 99, and the patient with this technician will make a site of the bleeding by isotopic scan or arteriography, sometimes injecting the patient and detect the site of the bleeding. And thank you. Any question, please?